There are many incision choices for women considering breast augmentation. The four standard choices for the placement of the incision are the inframammary or crease incision, the peri-areolar incision or around the areola, the transaxillary incision under the armpit, and the transumbilical incision. All plastic surgeons, and for that matter patients, will have incision choices that they prefer. I personally like the inframammary incision, and there are many reasons for this decision. The inframammary incision allows for direct access to the breast pocket and avoids having to go through any breast tissue for the placement of the implant. This incision can be used for any type of implant and is particularly advantageous for the placement of the shaped anatomic form-stable gel implants. Recent studies have shown that the inframammary incision has a lower rate of complications such as infection, bleeding, implant malposition, and capsular contracture. Some patients, due to either personal preference or anatomy, prefer the transaxillary or the peri-areolar approach. I find that these two approaches are less versatile and have a higher risk of postoperative complications such as infection and implant malposition. For the peri-areolar approach, the incision and dissection must go through breast tissue, and there are bacteria that are normally present in breast tissue that could potentially seed the implant, leading to an increased risk of infection and subsequent capsular contracture. There are also bacteria present in secretions from around the nipple and areola, and that can cause problems as well. Also, with the peri-areolar incision, there is a slight risk of not making a nice scar. If this scar raises up, it can be very noticeable. The key to the peri-areolar incision is to place the scar right at the junction of the pigmented areolar skin and the breast skin. In this fashion, the scar becomes more or less camouflaged. The transaxillary incision was very popular from the mid-1990s to 2006, when the only implant we had available was a saline-filled device. The advantages of this incision are obvious. There are no incisions on the breast. The problem with the transaxillary incision is that there is an increased risk of infection and implant malposition. The dissection of the capsule is done using an endoscopic camera with the image projected on a monitor. It is very difficult to place a gel-filled implant through this incision and prevent migration of the implant from under the arm. The transumbilical approach was never very popular and has fallen out of favor with the introduction of the new form-stable implants. At the time of your consultation, the location of the incision is only one of the many choices that we will discuss. Our goal, as always, is to exceed expectations, creating a naturally appearing breast.